Hi, everyone. So this is a presentation I did for the Fascial Manipulation Institute a couple of weeks ago. Unfortunately, they didn't make it public, so I've decided to record it to be able to share it with you if you're interested to watch it. So most of you know who I am, but if you don't, my name's Jack Williams. I'm a physiotherapist. I have a clinic in Melbourne Athletic Development, and I've certainly taken a big deep dive into learning about fascial manipulation, which will tie into this presentation today. The thing I want to give context to, though, just to help with understanding my evolution of my clinical practice and how it's relevant to this presentation, is I was very much a clinician who was very hands off, very much exercise focused. And that was certainly a key thing of my professional development earlier in my career. But it's only really been in the last 5 years where I've become much more of a hands on clinician. And that's very much been influenced by my knowledge and development in fascial manipulation. And that certainly had a profound impact on my understanding of the importance of manual therapy and its influence on movement, including motor control, which I'm going to explain today. So, a couple of key things I want to focus on today is just talk a bit broadly about motor control to begin with, because it's a topic that is often oversimplified without realizing that it is much more complex than we can reason. Understand and appreciate that the fascial system is essentially a sensory organ and is providing feedback to regulate motor unit recruitment. And then from that, thinking about how we need to expand our understanding of motor control by not just looking at it as a unidirectional entity, but thinking much more of sensory motor control to understand and appreciate the peripheral feedback and its influence on motor unit recruitment. So to begin with, I do want to highlight the fact that when we use the term motor control, it is a term that is vague and poorly defined. And in reality, depending on who you talk to, depending on the specific research that you look at, you'll see that different authors define motor control in different ways. So this is a table I've included that highlights that several different, very well-known authors using very different measurements and premises for motor control. So certainly in Australia, we talk a lot about the concept of motor control and seeing alterations in the more deep monoarticular muscles versus the more superficial biarticular muscles. But there are different models when you look at much more broadly from a purely mechanical lens, when you think about load, shear, and movement intolerances, abnormal movement variations, looking at length tension relationships. And in reality, what this really highlights is two things. One, there isn't a unified agreement of what motor control is. But more importantly, too, when you start to see that there are often multiple definitions, sometimes opposing, and that there is evidence to support these, that we have a complex entity. And in reality, when we look at motor control, it is a much more complex and dynamic behavior within the body than I think we often give it credit for. Now, again, motor control can often be very simplified. And a lot of the time when we talk about motor control, we talk about specific exercises to quote unquote improve motor control. And these are typically more basic exercises where we're often using internal cues to engage certain muscles with the intention to be able to quote unquote improve motor control. Now, there are limitations to this concept as well, which I'll talk a little bit more about. But the thing I want to highlight here is the concepts for how we improve motor control is very much from a top-down approach. So we're using voluntary contraction, using internal cues to increase EMG activity. And with this, trying to alter the motor unit recruitment at the level of the muscle or the neuromuscular junction. But then we have to ask ourselves, is motor control unidirectional? Now, in reality, when you look at different motor control models, I'd certainly recommend you to look at some of Daniel Walpert's work as a neuroscientist. And he's done a lot of work of highlighting the variability and the multidimensional layout of motor control. And this is certainly a simplified schematic, but certainly highlights that when we think about motor control, it isn't simply unidirectional. So absolutely, when we think about general movement, we have some plan that we create in our sensory motor cortex that sends an efferent signal through the spinal cord to recruit certain muscles to initiate movement. But it doesn't simply end there. When we get that signal from the brain, there's also a copy of that particular movement pattern that's sent to other parts of the brain. And the reason why we do that is we obviously have an intention of how we want to move, but we need to consider whether the actual movement that occurs physically matches the intended movement. Happens because of when we create that movement, we get sensory feedback in terms of the actual movement itself at a global level. Do we position our foot in the right point of contact on the ground? But also to very much from a sensory feedback as we're monitoring tension to make sure that we're moving in a safe and coordinated manner. And so when you look at this whole concept, we can see that this is very much a dynamic task where we're providing signals to the periphery, but at the same time getting a lot of feedback from different receptors when you think about just visually, and also when you think about tactile, but also when we think of sensory feedback in the form of mechanical tension to understand what parts of the body are working, what muscles are contracting, where is tension being created to ensure that we're moving in a safe and effective manner. And this is essentially highlighting that there are different sensors that are involved, from that central command to create the movement, but then the peripheral feedback in that central processing area to determine whether the intended movement matches the actual movement that's created, and more specifically, how that movement is created with the specific recruitment of certain motor units at the level of the muscle to identify the specific movement task that's been done. But this highlights a really key thing, that there is peripheral feedback. So we need to explore about how this peripheral feedback works. Within our periphery, within our myofascial system, we have many mechanoreceptors. And one that's been very well understood and explained are muscle spindles. So muscle spindles are little mechanoreceptors we find within the muscle that are essentially monitoring tension. Now, we could spend a whole lecture just talking about muscle spindles itself, but essentially think of them as these receptors with little fibers. They have what are called intrafusal fibers that are monitoring tension. And when we go to create voluntary movement, the first thing that happens is we get a signal sent from our brain to the spinal cord, to the right level based on the specific movement. And what gets sent out first is what's called a gamma motor neuron. And a gamma motor neuron causes the intrafusal fibers, the little fibers in the muscle spindles, to contract. And essentially, what that does is it provides an opportunity for the muscle spindles to monitor tension. And that's a really important thing because depending on the specific state of the muscle, inhibition may occur. So, give you an example. If you can imagine a muscle being really lengthened from stretching, if it's lengthened to a point that we're not familiar with, then there's going to be an inhibition of the muscle spindles as they send a message back to the spinal cord to go, there's too much tension here. We shouldn't be contracting because there may be danger in doing so. And when that gamma afferent, I should say, through the what are called the group 1A afferents is sent back to the spinal cord, depending on whether the amount of tension experience is safe, will then influence the ability to recruit what's called the alpha motor neuron. And the alpha motor neuron essentially recruits the motor units within the muscle to create contraction of the muscle itself. So essentially what we're seeing here is the way that our muscles monitor tension to ensure that when we contract, we're contracting in an environment that's safe to minimize damage or injury. Now, it's interesting to note that some of the research that's been done from Paul Hodges' lab in University of Queensland have looked at specific changes that occur in the erector spinae, specifically the multifidus, in a chronic low back pain model. And this is based on an animal model whereby they create a disc lesion to induce essentially chronic low back pain. And they look to see what changes occur to the multifidus. And for those of you who are unfamiliar, when we look at chronic low back pain, we can see that there are alterations to the motor control of the multifidus muscle. And that's an important element because the multifidus is very closely connected to the joint, and that can influence the stability or force transmission through the spine. And so interestingly, in their low back pain model, what they found was that you see an increase in the connective tissue thickness around the multifidus and specifically around the spindles. So we actually find that the spindles are located within the perimysium, and within these areas, we see that there is an increase in thickness and sometimes fibrosis if it's been long enough. that then impairs the function of the muscle spindles. Now, that's a very important concept to understand because that change in the thickness and the effect it has on the muscle spindles means that when you get that initial gamma motor efferent to recruit the muscle spindles, the intrafusal fibers and the actual receptor of the muscle spindle will sense too much tension. That then what feeds back into the spinal cord that causes an inhibition of the alpha motor neuron, the part of the nervous system that contracts the whole muscle to be recruited effectively. And so essentially, what their work has highlighted at is in the presence of chronic low back pain, we see changes to the connective tissue viscoelasticity that impairs the function of these muscle spindles. And so for a long time, when we looked at the development of chronic pain, and specifically chronic low back pain, but it essentially applies to any part of the body, we knew that early on you may get some inhibition. We would start to see changes in the muscle, particularly with an increase in the amount of adipose tissue. As you get into that subacute early chronic phase, we see that there is a pro-inflammatory state because there hasn't been a resolution of inflammation that happens from an acute injury. You get more fatty tissue infiltration, and you even start to see changes in fiber type transition. And then more long term, you see that because of the disuse and deconditioning, you see atrophy. But their work has really highlighted that the other element that has been forgotten about until more recently is changes that happen within the connective tissue of the muscle, where we see changes to the extracellular matrix that increases its thickness. That increase in thickness is associated with changes to the loose connective tissue, increasing its viscosity, altering the behavior of the muscle spindles, and certainly over time can create fibrosis as that increase in stiffness causes a laydown of collagen from the fibroblasts. So when we put this back to looking at motor control, we simply can't just look at it from a top-down approach. We have to understand that there is constant feedback from the periphery to the spinal cord and by extension to the brain that is influencing the behavior and recruitment of motor units. So this really highlights that when we think about motor control, we really need to consider using the term sensory motor control to highlight that it's not just simply a top-down approach, but a bi or even really multi-directional entity that's providing and getting feedback from many different sources, including the periphery, that influences the ability for muscles to be recruited. This makes a lot of sense too when you look at some of the work done by the Steckos, but also others, of highlighting the importance of the retinaculum. So when we talk about the retinaculum, we're talking about thickenings of the aponeurotic fascia that we find around the joints, specifically in the peripheries around our wrists and hands and our ankle and feet. So remember, we have that stocking of fascial tissue, and then it thickens to form the retinaculum. So here we can have a look at, we see the inferior extensor retinaculum of the foot. We also have the superior extensor retinaculum. The flexor retinaculum on the other side will have the perineal retinaculum. Now, the retinaculum are essentially proprioceptive organs. We see that they are very highly innervated, and we do find not only free nerve endings, but also some Ruffini and Pacini corpuscles, which are very important for proprioception. And we also know that following injury, things like ankle sprains, we can see changes to the thickness of the retinaculum. And that's a very important element to understand because similar to the changes in the muscle spindles, we can see that these changes in its thickness can affect its viscosity, the amount of mechanical tension that's experienced, and therefore influence the sensory feedback to regulate motor control. And this certainly makes a lot of sense when you look at in chronic ankle instability, we see changes to motor unit recruitment, not only in the lower leg, when you think about the calf, peroneals, the tibialis posterior, and so on, but even changes higher up within the kinetic chain. And this is because when you think about the retinaculum and proprioceptive feedback, that proprioceptive feedback is to provide feedback to help regulate movement, not just of the joint where the retinaculum is, but of associated joints required to create complex movement. So think about things like walking, running, jumping. We're not just simply moving our ankle. We have to create coordination through ankle, knee, hip, and even trunk. And interestingly enough, when you look at chronic ankle instability and changes to the retinaculum characterized by that increase in thickness, we see changes not only at the ankle, but even alterations to the recruitment of things like the gluteus medius that are important for hip control, but also within the trunk itself and trunk stabilization. And this is certainly important too when we understand the impacts of pain on motor unit recruitment. So when we experience pain in an area, certainly it can cause inhibition of the muscles in that specific area, but we can also see changes in the recruitment of muscles higher up in the kinetic chain within the same myofascial plane, but also within the antagonist as well. And so this really highlights that when we think about the fascial system, it is a sensory organ to provide feedback to help regulate motor unit recruitment and by extension, motor control. And more importantly, depending on where the specific changes in the connective tissue occur can help us to understand the specific maladaptations that we'll see within sensory motor control. So when I talk about some of the work from Paul Hodges' lab looking at changes to the muscle spindles in the multifidus, very much that's at a much more local level, where we'll see alterations to particular recruitment within the muscle or within the whole muscle itself. But when we start to see alterations in more superficial layers of the deep muscular fascia, so not the superficial fascia, but still within the epimysium, but also when we think about the aponeurotic fascia, that stocking of fascia surrounding our muscles, and certainly the retinaculum, the thickening of that around our joints, can help us to understand that alterations in motor control may not just simply happen at the level of the muscle that's affected, if we're thinking about the epi or perimysium, but also the particular recruitment, coordination, and synchronization of muscles within the kinetic chain associated with a particular movement task when we're thinking about moving our leg or moving our arm to position our hand for, say, grasping objects or throwing, or within our foot for running, jumping, change of direction tasks. Now, the other thing we need to consider too is whether motor control is consistent, because going back to, as I mentioned before, the concept of motor control being unidirectional and using specific motor control exercises for improving motor control suggests that the recruitment and coordination of motor units is consistent. Now, in fact, we see the exact opposite. So if you think about something as simple as moving, bending your spine forward and back, creating flexion extension of the spine, we see that in asymptomatic individuals, there is variation within the movement at a macro level in terms of the actual specific segmental movement of each vertebrae, and certainly changes in the specific EMG patterns of muscles associated with that movement. So when you think about flexion extension, a lot of the erector spinae and partly the abdominal musculature as well. And this is really important to highlight because this is in asymptomatic individuals. In fact, when you look at individuals with chronic low back pain, you see that the variation and the complexity of movement is reduced. You actually see that there is much more or much less consistency, much more predictability. And that's a really important thing to highlight because, again, we often associate that good movement should be consistent movement. But in reality, our sensory motor system creates some level of variability to ensure that we don't overload certain tissue structures. And that makes a lot of sense because if we're just using the exact same movement pattern, the exact same motor unit recruitment, we're certainly going to create fatigue. And with that, we can increase our susceptibility to injury. And we even see that with doing more complex tasks. Think about, say, kicking a soccer ball or a football if you're in Europe. Now, even in a relatively controlled environment, say like a penalty shootout, where the ball is positioned, you have time to make a decision of how you're going to kick the ball and where you're going to kick it. If you look at a skilled soccer player and you ask them to kick it to a particular point within the goal, every time they kick that ball, we see variation in their movement, even if the outcome, the actual position that the ball goes in, is the same. So you can appreciate in a very highly skilled soccer player, they may have the accuracy to be able to create a similar trajectory of hitting the ball and putting it into the goal. But when you look at the specific EMG behavior of how they complete that movement, we see that there is variation in that. And so again, for even highly skilled individuals, we're not necessarily looking at trying to refine the specific movement pattern, but seeing a fair bit of variability, but a consistency in the outcome. And this is a great figure because it really highlights why that's actually very important from an evolutionary perspective. Because even with relatively low demands of a task, the more movement variability we have, the lower likelihood of overuse. So if there's very large variability, or sorry, very large demands from the particular physical task and very little movement variability, there's going to be a very high concentration of forces to a small amount of myofascial and potentially articular tissue that can cause injury. So when we talk about motor control, be careful to make the assumption that movement and the same consistent movement pattern and EMG pattern is actually desirable. And this is something that this is just to highlight that when we think about movement, it is a complex task. We need some level of predictability. We don't want absolute chaos, but we don't want absolute predictability all the time. We want to see some variation in the particular movement pattern to ensure that we are distributing forces through different myofascial planes, spirals, to ensure that we don't overload tissue. And this is something that's very important when you think about from an injury mitigation standpoint, and certainly following injury, the importance of being able to have some level of variability to mitigate future injury risk. So what role does fascia have on motor control? Well, motor control certainly is an important thing that needs to be highlighted in the presence of pain, particularly with chronic issues. So chronic low back pain, neck pain are really common, but we see that in chronic ankle instability. We see it in things like tendinopathies and also other pain entities like patellofemoral pain, femoroacetabular impingement. So motor control is something that we need to appreciate can become dysfunctional. But the thing we need to highlight is that when we see alterations in motor control, that there are two things we need to consider. One, variability is important. And two, that variability is influenced by peripheral feedback. So when we create voluntary movement, we're sending a signal from the brain to the spinal cord to create movement, but we're also providing feedback all the time from the periphery. And that's to provide information about things like proprioception, understanding where mechanical tension is to make sure we're not potentially creating tissue damage if we're creating too much strain, but also too to understand that the more peripheral feedback we have and the more normal behavior of the fascial tissue allows us to create variations in how we create little minute changes to the particular fascial planes or spirals that are being used to create movement and alter the specific patterns to be able to distribute mechanical forces in a more non-uniform way to mitigate injury or overuse. And more importantly, in the presence of pain or changes to connective tissue, we can see a level of inhibition that can affect the motor control or motor unit recruitment. That's characteristic of a lot of chronic conditions, but also perhaps influence or reduce the amount of variability that can be created because certain fascial planes may not be able to be used as effectively because of the inhibitory signals being sent, and therefore the particular patterns that are used to create movement to try and offload those particular planes. So optimizing motor control requires normal tissue biomechanics. And ultimately, when we think about human movement, we are dealing with a complex system. And I mean that in the sense of there's obviously a lot of factors to consider with how we create movement. There's the peripheral feedback, as I've discussed. We need to consider about tissue capacity. So we have variations in each individual's range of movement, strength within different areas of their body, flexibility, power, and so on. The mechanics of how we actually move based on our prior history with completing a particular task, based on our anthropometrics, and certainly environmental factors too, because most movement doesn't happen within a black box. We have to navigate certain physical environments. If we're playing sport, we have to be able to take in information of opposing players, where the ball is, and so on. And so ultimately, motor control is a very complex entity, and it's the influence and the connection and interaction of these modulators that influences the output. But when we go back to thinking of the importance of the connective tissue, the particular mechanics of the connective tissue is vital to provide appropriate sensory feedback to ensure that we don't get inhibition and that we can maintain a level of complexity and variability with how we create movement based on tissue capacity and biomechanics. And so for those of you who think about using specific exercises to improve motor control, these are certainly maybe fundamental and important as a part of the overall management plan. But we also need to consider how, based on that person's presentation and specifically based on their history, that can give us clues to alterations in fascial biomechanics that can influence the behavior of the mechanoreceptors embedded within the connective tissue. When we think about things like muscle spindles, Golgi tendon organs, free nerve endings, and how that influences the recruitment of motor units and also the proprioceptive feedback that it provides to the central nervous system to regulate motor neuron recruitment, not only within the affected region of the body, but also within the kinetic chain more proximally or distally. And so thinking about the variables or parameters for motor control, absolutely we need to think about how we can use exercise to help improve motor patterns, improve tissue capacity, but also thinking at before we even get to that level, we need to think about how peripheral tissue mechanics can influence that sensory feedback and how we can use certain manual therapy modalities, and certainly something like fascial manipulation being very systematic and methodical for how we identify where those specific changes are within a particular fascial plane or a diagonal or spiral that influence that movement. And over time, build up doing more local and then eventually global movement to restore effective movement, but also making sure that we restore a healthy level of variability and complexity within that movement. So if you do have any questions, please feel free to send me an email. Happy to share any resources I have or answer any questions you have related to the presentation.